Yeah, so we are deep in the clinical stuff right now. I'm going to kind of move towards a little bit more of the technical things, right? So attachments. What do attachments help with? That is the first question. So attachments they are necessary for treatment because they help provide more surface area for the aligner trays to actually, put force onto, but they also have features like retention to actually help keep the trays on. So, quick story about these. When I first started doing aligners, the practice that I was at, there was a senior doctor who was there. And I was kind of doing my thing. I was, pretty comfortable, but, still early on, so there was a lot, obviously, that I didn't know. And one of the patients that I was working on, his lead assistant was working with me for the day. And she's experienced assistant, kind of one of those where it's like, they know probably more than a lot of dentists do. So I was like, awesome, you take care of this patient. I'm gonna do my checks and I'll be back. And so I came back in and she, I did the check to see where the attachments were at. And then there was composite on the entire buccal surface of the tooth and then the attachment as well. So she basically just put all this composite on there. And then so I was like, hey, so why did you cover the entire tooth surface? And she's like, oh, that's how, Dr. So-and-so usually does it. And I was just like, okay, that's weird. That's not how I kind of was taught or know of. But I didn't necessarily know. I still had her. I went in and I was like, okay, I'm gonna remove this. I have to just put the attachment on the spot. And that was one way that something was done a little bit differently. But these are those myths that are out there, right? This doc wasn't really doing that many aligner cases, and they were an early adopter with aligners. So I don't know if in the past there was a time where the rule was you put attachment or you put composite on the entire tooth surface, but that's not how it's supposed to be now. The other thing is not only did she do that, she also didn't put attachments on the molars. And so I was just like, why? I was like, there's a couple attachments on these molars, did they fall off? What happened? She's like, oh, I didn't put them on there. I was like, well, why not? And she was like, oh, well, Dr. So-and-so said, if it's hard to get back there, to just ignore it because they're not necessary. And so I was just like, that doesn't sound like good logic. I'm sure there's a reason. So I'm saying all this to let you guys know that attachments are necessary. If they are in your plan, there is a reason and a purpose, because they are either putting force onto the tooth or they are helping that the aligner stay on the tooth. Okay, so don't ever think that, oh, this is an optional attachment. If you don't want to put attachments on certain teeth, do that in the plan before you even start, right? Because it is a domino effect. There's a lot of forces happening when we're trying to move teeth, and so every attachment has a purpose. Now, there are several types of attachments, specifically for Invisalign. I know we have different brands, but for those of you who are using Invisalign, I'm gonna go over the different attachments and the ones that you need to kind of focus on and understand better. And then for everybody who's using other brands, they don't have as much variety, right? Invisalign has, they've got conventional, optimized, all these shapes and sizes, whereas most other brands have gone, pretty conventional in the sense of you're either gonna have a horizontal or you're gonna have a vertical attachment, and that's gonna assist you in whatever movement you're trying to do. So for a horizontal attachment, right? This is one that is on the tooth, and that is going to help either extrude the tooth, bring it out of the bone, or intrude the tooth and push it into the bone, okay? It helps with those movements. Vertical attachments are going to help you with any rotations or translating of the tooth. And for the horizontal attachments, this is what they would look like, right? So horizontal attachments, I like to put these on premolars, and I like to put them on every case that I do. And the main reason why is because a horizontal beveled attachment is going to help for anchorage. And so if you think about when a tray goes onto the tooth and it snaps on, if it has these horizontal attachments on the premolars, it is gonna literally help the aligner almost click onto the tooth and stay on. And that is what helps the other movements actually happen. So this is not actually moving the tooth anyway. This is strictly meant for anchorage, and the word anchorage in this case is anchoring that aligner onto the tooth, okay? And then you've got, these are some visuals here. So the vertical attachment at the bottom there, you can see that is what it's usually going to look like for the other aligner brands that you use. Invisalign has this thing called a raindrop or a teardrop attachment. So that is one of their optimized attachments. And they use this because they have basically created it in a way to assist with rotations. Now, if you're using Invisalign, those are totally fine to use. However, if it is more than 15 degrees of rotation, I recommend you just use the vertical attachment because the vertical attachment has more surface area. So with more surface area, there's more opportunity for force to be applied to the tooth, and that's what helps rotate that tooth. That teardrop attachment, the whole purpose of that is it acts as like a handlebar for the force to be put on. So like if you've got a canine, which is, you know, similar to this, right? And you're trying to rotate it, to have plastic kind of wrap around it and try to like rotate the tooth is very difficult. But if it has a handlebar, then you would just put the force on that handlebar and you can rotate it over.
So you said the rectangular vertical attachment is for more or less than 15 degrees?
So 15 degrees of rotation or more, I will always put in a request, a modification to use a rectangular vertical attachment. And with attachments, bigger is better. Okay, so the bigger the attachment, like I said, the more surface area, the more force. So that is, that's the rotational attachments there. Invisalign users, multi-plane attachments are these half moon shaped ones, okay? I don't think other brands like SureSmile, ClearCorrect, or even Candid uses these, but for Invisalign, you'll see this pop up, and for whatever reason, this is the first thing they'll kick it back, especially on laterals. If you ever see this multi-plane attachment, it's usually on the marginal ridge there of the laterals. You just replace it with what's called a lateral retention attachment. And the lateral retention attachment is going to be the best attachment for you to use whenever you're doing movements with laterals outside of extrusion, okay? And we're about to dive into this stuff here. And I'll show you a picture of the lateral retention. This double spiked attachment, they showed it to you in the video, but basically this is where essentially you can have force being applied from this direction and this direction, and that is what ultimately will torque the tooth, right? Because you've got two areas on the flat surfaces where force is being applied. And so, you know, let's say they'll put level 10 force here, level 5 force there. So it's ultimately gonna move in the direction in that way, but it'll involve root torquing. Now, like I said earlier, torquing is tough, so you don't want to always have that root torque in, okay? That can help with translating centrals as well, right? So it's actually kind of moving them through the bone there, and they do that by using force in two areas. I know I mentioned this earlier. This is called a G4 extrusion attachment. That's Invisalign's fancy way of basically, you know, using a horizontally beveled attachment on the anterior. So if you are trying to close any anterior open bites, if you're trying to do any type of extrusion, you want that horizontal attachment because that is the surface area where the force can be applied. So the way these work are, if you didn't have this attachment and you tried to extrude this tooth, you are just hoping that the plastic can grip on the front and back of the tooth and like pull it down. But if that happens, it's just gonna slide off the tooth. So what you need is you need a horizontal attachment so that way when the aligner grips on and it tries to pull, it actually hangs on to something, and that's what that attachment does, and it will pull the tooth down. And if you are extruding 0.6 millimeters or greater, then you want to have that bevel towards the incisal, right? And so the bevel is basically like the kind of sloped surface, and so you want the slope to go in the direction of the movement you're trying to achieve. So for this example, extruding a tooth, you want the slope, you want the bevel towards the incisal, so that way when the force hits that bevel, it ultimately goes into a, in this case, a downward motion or towards the incisal. And yeah, just a rule of thumb, when people are like, oh, which direction should I place the bevel? It's always, bevel goes in the direction of movement from a horizontal force. So a visual here is if you've got, I know I just kind of showed it, but kind of at scale, if you're looking at it from the size and you've got a bevel, this is on the central tooth. If you've got a bevel going down towards the incisal, the way the force works is the horizontal force is going to hit the bevel, and then ultimately this thing will slide down, right? If you had a bevel in the opposite direction, like if it's like this, and you're beveling it this way, that force will translate up again. And so that is essentially how you would look to extrude mandibular anterior teeth, right? Because incisals are opposite in both arches. So that's one way to think about it. That was something for me in the beginning was kind of confusing. It's like bevel, like what is that? But always, wherever you want to go, slope the bevel in that direction.
So if you're a dentist who wants to get confidence with aligners and you just don't know where to start, be sure to check out one of my free trainings. But if you want something that's more structured with some implementation resources and support, then you might be a good fit for our course, Aligner Blueprint. It has helped hundreds of dentists generate over $9 million in aligners alone, and they've all been able to do cases with confidence. The links for all those are in the description below, so you can go ahead and check that out or go to our website, clearalineradvisor.co, and that's where you'll find all this information.
Now, this is specifically for Invisalign. It's called a G5 deep bite attachment. And what this does is this helps aid any type of anterior mandibular intrusion, right? So if you want any of these teeth here to be intruded, Invisalign has this deep bite attachment. Essentially what that is a horizontal attachment for all other brands that allows for the reciprocating force to be applied. So I don't know if you guys remember in that previous video, but when he was talking about, if you're trying to intrude, you have to have teeth that take an opposite force. And so that's what this is. And I'll give you guys a protocol in a second to kind of fully map out whenever you do your intrusion cases. Again, I know some of these words, it's like, what is G6, what is G8? Invisalign kind of does that, but I want you guys to understand it so that way, in case you ever do use Invisalign, you kind of know how to go about it. So the G6, posterior open bite prevention. So like totally a mouthful. But this attachment, the G6, is meant to help you prevent posterior open bites from occurring. Now, in what situation does this make sense in? So whenever you've got basically space between your canines and the posterior segment, whether it's the maxillary or the mandibular, you need to have G6 attachments on the posterior. And the reason being is when there's a space between the teeth and you just want to move everything from the front to the back, ideally that would just happen, right? However, when you are in reality trying to bring things backwards, the teeth in the back are also going to want to come forward because everything is moving, and that's how the forces work. So while you only want the front to go backwards, if you don't have something on there to prevent that from happening, you will end up getting these teeth all to come forward and these to come back. You would tip, and then you would get probably the worst posterior open bite that you could ever get. So that being said, if you're not using Invisalign, I do believe that the other systems kind of already engineer that into their ClinChecks and their treatment plans, okay? So it's something that you don't have to necessarily worry about. If you do have a question on it, you can message the tech, where the specific case of this happens whenever you're trying to distalize canines. And if you have that happening, you can always ask them, like, what is being done to prevent the posterior teeth from coming forward? And 9 times out of 10, they'll tell you, yeah, that's already engineered into it. And so this is where things start to get a little like, well, why isn't this just done across the board? Well, the first ClinCheck that you get back and the way these like algorithms work when the case is being set up from Invisalign, they're very generalized. It's very broad strokes, and it kind of leaves it up to the provider. And so these are the things that you want to just kind of have in the back of your mind as like signals to just double check. Again, this can be very overwhelming if you're not starting with like the cases that you are supposed to in terms of the case selection, but everything flows downstream. And so what I'm trying to do is I'm trying to shrink the field for you guys to focus on, right? And so if you're taking on every case and trying to solve everything, then yeah, there's going to be a lot for you guys to take in and it's going to get overwhelming. But this pathway, in terms of the types of cases you're taking on, these are the things, right? So in your spacing cases where there's distalizing the canines, you want to make sure that you've got a way to prevent those posterior teeth from coming forward, okay? So simply put, with Invisalign, it's just those attachments, you're good to go. With other brands, that's already engineered into their sequences and their movements. The G8 attachment for Invisalign is a new attachment, or relatively new. And what that does is that basically show of hands, who's using Invisalign again? Okay. So the G8 attachment basically helps prevent those molars from tipping outwards. And I'm going to show you more about what that actually looks like, but that's the purpose of that. So if you're doing like molar expansion, you want to make sure you have that G8 on there. I'm not a big fan of the molar expansion, and I'll tell you guys in a bit why, but if you do it, that's the attachment you want. This is what the lateral retention attachment looks like. So basically, to remind you guys, for any movement that you're doing with lateral incisors, if it's not extrusion, then the lateral retention attachment will help you in your cases because it fits really well on the tooth itself, and for Invisalign specifically, that is what helps just with the plastic. That's what helps basically like work and get the best movements out of them. So bite ramps, I'm a fan of. I love them. I think they're great. When we do retainers for patients, we put them in there. The only two scenarios we won't do bite ramps is if they already have an anterior open bite, because if they're already open, you don't want to counteract that force. And then if they've got minimal clearance to begin with, right? So I could almost bet your office manager potentially had minimal clearance plus that clenching and grinding habit, and that's what is why the bite ramps probably didn't help them. But with bite ramps, those are pretty much I'm putting them on all cases because it is one way to prevent posterior open bites from happening, which we'll get into in a sec. And then something to remember with bite ramps. So what is it? It is basically on the aligner trays themselves, okay? This is not a composite material. This is not an attachment. Attachments are bonded onto the teeth. Bite ramps are already engineered into the tray, and it's on the outside portion of it. So when the patient snaps the aligners in to their maxillary arch, they will feel like a protrusion on the back of their teeth, and that's what the bite ramps are. So your team does not need to put composite in there. Sometimes we've had docs or teammates like do that. Does not need to be filled with composite. It is strictly there to help create some space so that way when patients bite down, they're not biting down directly on the opposing arch. They're hitting that ramp, which helps open up some space also in the posterior. Some people like to think of it as like an anterior deprogrammer. We like to use them on retainers as well because it helps, honestly, it just helps take a lot of the force off of people who are clenching and grinding. So that's the protocol that we follow. Power ridges. So power ridges help, again, they help with any type of like root torquing movement. What it does is it's engineered again into the plastic and it puts force right on this portion of the tooth, which helps get it kind of that torquing movement, right? Because if you've got force from the tray and then now you've also got this power ridge, that's how you'll get all the force going in one direction. So it's like force that's closer down to the central point of the tooth. Something to note about these is you'd never want more than 2 in a row. And the reason being is because when you've got a power ridge, that is on the inside of the tray. So the power ridge is between the tooth and the plastic. And what that does is that it causes the tray to kind of sit off the teeth a little bit. So if you've got 3 of them in a row, I mean, the plastic isn't really going to be touching those teeth, so you're going to sacrifice a lot of movement there. So if you ever see more than 2 in a row in your plan, you just message them and you just say, please stage power ridges so there's no more than 2 at a time, and they'll do that for you. Okay, so this is the protocol we use for anterior intrusion. It's the Galler anterior intrusion protocol. And this, I'm going to read it in a way that works for Invisalign and then for everyone else. So whenever you're trying to intrude mandibular anterior teeth, this is what you would want to do. So you would want to have bite ramps on lateral incisor to lateral incisor, right? So 7 to 10. You want to have lingual attachments, yes, lingual attachments on your mandibular canines 22 and 27. And then you want to have horizontal beveled attachments on maxillary first and second premolars, as well as mandibular second premolars. So all the premolars except for the mandibular first premolars. Now on the mandibular first premolars, you want the G5 deep bite attachments, okay? What's the purpose? Why? So what this does is this protocol helps you get the anterior intrusion. What the bite ramps do is it prevents excess force on those mandibular anterior teeth. The lingual attachments from the inside basically helps do the whole concept of like reversing the force, right? So when the trays are snapped on, now you've got force being placed on these canines in a downward motion, right? And that's what helps drive those down. And then also the attachments on the outside of the first premolars, those G5 deep bite attachments, that is what reverses the force that's being ultimately placed on the mandibular anteriors. Basically, to make that even simpler, if you want to get anterior intrusion, follow this protocol and the teeth will intrude, okay? If you're not using Invisalign, instead of the deep bite attachments, you're just gonna want the horizontal attachments on those mandibular first premolars. All of those attachments will help get that force to intrude and drive those mandibular teeth down because the tray will be seated and the force will be distributed on the teeth that need it.
So if you're enjoying this video or found it helpful in any way, I'd really appreciate it if you could just share it with one of your dentist friends. Just copy the link, drop it in your favorite group chat, or post it in one of your favorite Facebook groups or communities, and just share it. That's it. My mission at the end of the day is to make aligner education accessible to as many dentists as possible. And so by sharing this video, you're gonna help me move closer to this goal, and I really appreciate your support.
Okay? So, some tips when doing clin checks, treatment plans, stuff like that. So first of all, don't review it with your patient. Who here does? Who like sits the patient down, like who brings the patient back, and don't worry, like I used to do it too, but show of hands, like part of your workflow, like who calls the patient back to review the treatment plan? Nobody. Okay, cool, well good. I'm glad you guys aren't doing it. Some people do. Some docs think that if they do the consult and then they like do the treatment plan and they call them back and they sit down and they review it with them again, that like that's important, but it's a wasted step. When we get into workflow, I'll kind of dive more into it, but I'm just glad you guys don't do that. Second tip, don't rely on the techs. So these modifications that I've been kind of mentioning to you guys, if you rely on the tech, like basically don't think that the tech knows everything that's going on, right? You're the provider, you're the clinician, you have protocols to follow and you know what needs to be done. Now they will help you fill the gaps, right? But when you need to know kind of what you're looking at and what to ask for. And so I know a lot of this stuff kind of came at you guys quick, but I tried to simplify it so that way it's like when this happens, do this. And it's also a way for you to kind of check on these treatment plans when they come, like, okay, is everything here lining up? Because I say that because you're rarely gonna approve the first treatment setup, right? A lot of docs believe, so did I, because I thought, why is this not a thing? But everyone thinks that like you submit the plan comes back, you hit accept, you move forward. So who does that? Or who did that?
I used to do it. I was like, it's just magic, right? It just
Yeah.
happens. And that's actually what took me away from Invisalign because I was like, there's no way this just works like this.
Yeah. Well, and then you probably got cases that where it didn't like work like that. Happened to you?
Yes, absolutely.
Yeah. So that is, yeah, something to just remember and take into account. Like it's like you're always going to have to make some type of modification. So if you just assume like, all right, I got to like look at this and maybe there's something that I got to do. It's just a matter of figuring that out. That's the best way to go about it because you don't always need to make I'm not saying that these treatment plans are so wildly off. I'm just saying like these are a couple of the little tips and tricks to use so that way you can get more predictable results. And it'll save you a lot of time and you'll get a lot of sleep back because you'll actually get the results that you want. For those of you, like if you want to start to use 3D controls, this is obviously for people who have done more cases, I would recommend it. When you're just starting off, I don't really think you need to kind of get involved with that. That's a little bit kind of next level. But the 3D controls help you kind of just literally like move the teeth the way that you want. And the benefit there is more control, and you'll get faster kind of time between getting your plans back. When you're making comments like I was mentioning earlier, you want to keep your comments to the text specific and in bullet form. So don't write out full-blown stories. Don't add color and detail. Just tell them in bullets, this is what I want. I want attachments on this tooth, and then you can, and if you want to say for this purpose, right? Like right there, I said, add lateral retention attachment to number 10, remove round tripping on number 23. Like that's it. Like just tell them what you want, because a lot of these texts, if you didn't know, they are in other countries. So English is not their first language. And so when you add all these, you know, very vivid details, they're kind of just like, I don't really know what this doctor is talking about. What do you call them? The Costa Rica?
Mm-hmm. Yes.
You had like a fun name for them.
I've always known them.
Yeah. So they're, and again, they're trained, but there's a certain level there. And then again, it's just the English barrier that you just need to be aware of. And then, yeah, when you're also looking at plans, you want to look out for unnecessary movements, right? So very simple one to look out for is like root torque, okay? If you've got root torque happening, just eliminate it. Ask them to remove root torque on, you know, the teeth that have it. Another thing that you can look out for in terms of unnecessary movements are things like premolars. And I've got an example of it, but if a premolar has a lot of rotation, but it's not really improving anything, like that wasn't even the chief concern, you don't have to move it. Like you can kind of leave it be. If you're focusing on the anterior segment, focus on the anterior segment, because trying to move things that are already in a stable position can actually just cause more problems. So you want to just make sure it's like, okay, is everything that we're moving actually necessary? And then if it's not, you would request them to not do that. IPR versus expansion. So this is something where, you know, you definitely, I'm a fan, expand where you can, right? Expand where you can, and then do IPR. Do IPR in a way that is going to make sense for you. And so what I mean by that is you want to reduce the IPR wherever possible, and then just do the expansion where you can. Some cases, it's just not going to be the case, but you want to make sure that that's something that you're looking out for. Now, the last bullet here is just double checking photos to ensure that cases are mounted correctly. So when you're doing this, when you are submitting photos on the case and they give you the ClinCheck or the treatment plan back, sometimes the visual that you see when they start off is not going to match. So what does that mean? When you're back, like let's say you look at it and the back teeth, there's no occlusion, but you know that the patient is occluding on their posterior teeth. That means that the photos or the records that you gave to the lab, there was an error, something went wrong. And so they just didn't mount it correctly. And so if you don't check that when you get your plans back, the rest of the case is not going to happen, because it was doomed from the start. So a way to counteract that is when you're taking photos, part of the protocol is just having the patient bite down on articulating paper before you take the photos, so that way when the photos are submitted, the tech can see, oh, okay, like they're definitely occluding on these teeth, and so the more information they have, the better.
So if you found one nugget in this training and you found it valuable, you need to go watch this video that I made. We go deeper in these aligner concepts. I'll see you in there.